and then levator scapula. What does what part of the scapula does the levator scapula attach to? It's like the upper medial part between the superior angle and the root of the spine of the scapula. So you're going to feel that up in there. All right. And then as far as the thoracic outlet area, there's some specific things that you can possibly be able to palpate. Again, we're talking about the scaling muscles, cervical rib, and then the coracoid process in the pec minor. Right now what we'll do is I'm just going to do like a quick overview of the special tests that we're going to cover. Then we'll take a break and then we'll come back and actually practice them. So what's the inert tissues again? Bones, cartilage, ligaments. Yeah. Okay, joint capsules. So those are going to be things like foraminal compression tests. I've kind of mentioned that a little bit before. Basically, you're compressing the joints. Jackson compression test is just another version of the foraminal compression. Distraction is where you're pulling up like this. And then shoulder abduction relief test. What that is that if the nerve root's putting pressure on the brachial plexus, you're basically taking the strain off of the brachial plexus. So if they have a nerve root problem, a lot of times putting the arm up like this is going to relieve the symptoms. Then you're going to have things that are a combination of inert and contractile. And the Donahue test, I kind of mentioned that a little bit before. It's basically a combination of passive range of motion at the end of the range. I'm doing something like this, I'm stressing the ligaments, whereas if I back that up with doing an active resisted muscle testing, then I'm testing the muscles. So if they have pain on active resisted, that's going to indicate contractile tissue problems, versus pain at the end of passive range of motion is going to indicate more inert joint problems, or inert tissue problems. All right, then we'll talk about neuro, and these are neuro special tests as opposed to like the 5-minute neuro dermatomes, myotomes, reflexes. So if you remember, basically when we talk about the types of things that you do for nerve tests is either you actually stretch or traction that nerve, and then the shoulder depression is going to be one of these, where you're pushing down on the shoulder and going like this. So it's stretching the nerve on this side, but what are you doing on the other side? Compressing, right. So you could have a facet joint problem on this side, or a nerve root traction problem on this side. Then the other thing is that you narrow the opening that the nerve goes through. So in a way, actually also this from a compression test or some of these other different positions are also testing the nerves. And then Valsalva, that's putting pressure on the nerve, actually the intrathecal pressure. Basically what Valsalva test is you have the patient take a breath in and bear down as if they're trying to move their bowels, and that's increasing the pressure surrounding the whole spinal cord. So it can indicate nerve root, disc problems affecting the nerve roots, spinal tumors, other things that affect anything to do with the dura. And then Soto Hall is more of kind of a nerve traction thing. So when you're bending the head forward like this, you're tractioning the nerves. Okay? Basically, in a general sense, like I mentioned before, anytime you're doing anything into flexion of the neck, pulling the legs up like this, you're tightening all the nervous structures. Anytime you're doing something back like this, you're compressing the joint structures. And then vascular, we have a swivel chair test, and then the cervical quadrant test. The swivel chair is where you put the patient on the chair that swivels, and then if my head's not moving and I'm swiveling the chair like this, am I affecting the vertebral artery? Yes. Am I affecting the inner ear? No. But if I turn my head like this, am I affecting the artery? Yes. Am I affecting the inner ear? Yes. So if you don't get dizzy when you do this, but you get dizzy when you do that, it's probably more likely an inner ear problem. And if both of them are affecting it, it's more likely to be vascular. And cervical quadrant is the patient supine, and then you just put the head back, you extend, lateral flex and rotate towards that side. That's pretty much the only test where you actually need a table to do. So we probably will, you understand the concept of that, but we'll practice that more completely when we get tables out. Because for this week, we probably won't need to put out the tables. And then we talk about neurovascular things for thoracic outlet. So these first couple ones are going to be things that have to do with moving the neck. And what I mentioned before, when you're moving the neck, what types of tissues are you involving there? Well, in this case, it's the scalenes. Any structures that are going to be in the neck, so it could either be cervical rib, or the scalenes. When we're talking about thoracic outlet, it's not really just inert or contractile, it's kind of mixed. So things that are moving the head, you're talking about the scalene muscles, cervical rib, things that are closer to the center of the spine. Then as you progress outward, you talk about costoclavicular types of things. That's where you're talking about moving the arms, shoulders back and down. And then when we get out to the coracoid process in the pec minor, what position is going to aggravate that? Like this, after abduction. So there's a couple tests. There's one like this that we'll do. Right? All right, so for cervical range of motion with the inclinometer, what I did is on the medical ones, it has like two little tips, so that because if it's just flat like this and you try to put it on top of your head, it's rocking and rolling. So I just taped these two little magnets on here. So now it fits better onto the head. And then, so I'm going to put this basically on the top of the head and then put it on make sure that it's centered on 0. And then I'm going to put this on just basically on the top of the shoulders. And then I want you to bring your chin forward down toward your chest. So normally I'd be standing on the other side and looking at these. So you're going to take whatever number this one is and then subtract whatever this one is.
So that one doesn't stay at 0 then?
It may or it may not. The more that you move the thoracic forward, I don't know, Kate, what is it on right now?
0.
Okay, so a lot of times it's going to be 0, but slump your shoulders forward a little bit more. So if somebody does something like that, then what you're doing is you're able to subtract this out. So let's say if this is 70 and this is 10, then you're going to have 60. Okay? Then come back up. And then bend backwards. So the same kind of thing. I think this one moved a little bit, about 5 degrees maybe. Okay. And what's this one, probably 85? So then 80 minus 5 is going to be 75. Okay, come back here. And then let's have you turn the chair face that way, face the board. So here, now again, we're going to put this on here. We're going to put this at C7. And then I want you to bend your head to one side, bring your ear toward your shoulder. Okay, so same thing. I think this one's still pretty much in 0, right? It's at about, probably about 70. No, what am I saying, 70? No. Yeah, just past a little about 40, 45. So anyway, whatever this number is, you subtract this one out. Okay? Okay, that's good. So for rotation, you only need one, and then you have the patient lay on the back. So let's say I'm laying back like this, and then you just go like that. Okay? So that one you're going to do supine.